So we're going to talk about why healthcare costs are so high. And this can seem pretty complex, and so I think it's best to go ahead and start with a patient story to try and understand the problem, and then also some of the solutions that have been proposed for healthcare costs. So let's start with this person who is a man who woke up one morning and suddenly had very high fever and his belly hurt a lot, and so he calls his doctor and goes to see her in the clinic. And I've just drawn a little stethoscope here to denote that it's a clinic. And the doctor examines him, says, yeah, you do have a fever. Your belly's pretty tender. I'm worried you have appendicitis. I'm going to go ahead and send you down to the emergency room. And so our patient goes to the emergency room where he sees a different doctor, has some blood tests, maybe some x-rays. They agree appendicitis is really a strong possibility, and so they send our patient to the operating room where a surgeon sees our patient, removes his appendix, goes ahead and has him stay in the hospital for a few days to recover from the surgery. And after our patient is in the hospital for a few days, he's still not ready to go home by himself, so he may have to go to a brief stay inpatient rehabilitation facility to kind of get back on his feet. Finally, he's all better. He returns home, and then he may go back and have one more visit with his primary care doctor. So the good news is that our patient has really gotten through what seems to be a major medical problem. However, the issue is, how is this going to get paid for? It turns out that our patient or our patient's insurer is now, look at this, going to get all these bills. It's going to get one bill here, one bill from here, one bill from here, one bill from here, one bill from here, and then after they return to the primary care doctor, yet another bill. Look at that. That's 1, 2, 3, 4, 5, and 6 separate encounters, 6 separate kinds of bills. You can see this care is highly fragmented in terms of how the costs are being accounted for, the bills that are being sent. And in fact, there's also not that much incentive for any of these people to talk to each other because they all just send their bills in isolation. This causes a lot of problems for our patient, and this type of billing where everybody sends their own bills, those bills get paid, is referred to as a fee-for-service system. And for many years, this has been the dominant way by which medical bills are generated and paid. And I think you can immediately see that this is very problematic because you can send bills that are whatever cost you want. You can send as many of them as you want. And in fact, the more bills that are sent, the more care that's given to the patient, the more the doctors and providers get paid, which sort of encourages a lot of overuse. Let's think about this as an analogy. Suppose you own a house and you want to do a renovation of your house. And so you hire a contractor and you make a deal pretty similar to the deal that providers make with the healthcare system, fee for service. You put in and do whatever work you want and we'll go ahead and pay for that. So think about that. If you're a contractor, this is the perfect client. You're going to put in a door, and then because you get paid for every door you put in, you're going to put in another door, and then another door. And then maybe because you get paid, no matter what kind of door you put in, you get paid more for a fancy door, you're going to make a special window here and cut that out in an unusual shape and maybe even put on 2 knobs because you get paid more for that. And then you're going to put in tons of windows too because you're going to put in as much as you can get away with because you get paid more and more for doing this. And you put in some fancy windows. And then you have a roofer, and the roofer is going to put in all kinds of extra roofing stuff. And the bottom line is, look at this. This house doesn't look any good. It's not really what you really want your house to look like. The quality is not really great. Because of the way the system pays for stuff, they only consider the volume and the cost of your care because that gets paid out. They don't really consider quality. This is thought to be at the heart of problems with our healthcare system. So let's take a look at this with this simple equation, which is the cost of your care is equal to the price of a service times the volume of services. So, in other words, the total amount that you pay or your insurer pays or the country pays is going to be equal to the prices of each of the little widgets you have. In other words, for each x-ray, each checkup, each visit to the OR, there's going to be price, and then the volume of services. So let's compare that to the house you just had built. So the volume of services is going to be, say, the number of windows and doors. And as we said, your contractor is going to want to do as much volume as possible. In addition to that, the price may be high. This is going to be how fancy your windows and doors are. In other words, you're not going to have a simple window and door. They'll put in ones that are more expensive because you get paid more. So the fee-for-service system causes problems with incentives here. It encourages care that is high-priced and also encourages a lot of it. Because what's really the outcome, what the provider sees, is just simply that they can get paid more without real accountability for quality. Now, many doctors we know really want to do what's right for patients, but when this is how the incentives are structured, they may not necessarily get rewarded for that care, and then as a result, over time, more and more they're going to de-emphasize quality and keep maximizing cost. And that's really what most economists believe has happened with the healthcare system thus far. Just a word on the price and volume. It turns out that private insurance and Medicare seem to have slightly different reasons for why their costs have increased. It turns out that private insurers have to negotiate with their providers. And part of the negotiation is what price they're willing to pay. So they might say for an x-ray, we'll pay a certain amount. And then the people who own the x-rays will say, no, we want you to pay more. So it turns out private insurers generally don't do very well negotiating with prices. And as the years go by, prices have really increased. So in the private insurance market, the real explanation for cost is increases in prices. On the other hand, Medicare, which is the other huge payer of care, fixes prices. That's the federal government. They're going to say, take it or leave it. This is the cost of x-rays. This is what we charge, what we're going to pay. This is all you can charge. So there is no negotiating on prices. Interestingly, over years, the providers have adapted and they seem to increase Medicare prices actually by doing more and more. So they have more visits. They do more tests. They really find that the increases in increases in costs in Medicare are driven primarily by increases in volume. The effect on either Medicare or private insurance, however, is the same, which is that costs continue to increase. Let's talk for a minute now about, well, how have different individuals and organizations tried to fix this system and modify the fee-for-service system to offer greater value and accountability for quality of care, potentially also with lower prices. So I'm just going to erase the screen for a minute here and start again. So let's sort of start talking about this spectrum that payers and buyers of healthcare have found themselves on. On the one hand, we have fee-for-service. So that's the system we just talked about. It turns out that we can move from fee-for-service down this pathway to a greater accountability. And we are going to sort of talk about how this is now happening and sort of going along the spectrum from sort of the small changes to some of the bigger changes that have happened. And the first stop is going to be right here, which is a strategy called paying for performance. So that's sometimes abbreviated as P4P. And this is really simple. So suppose you provide a medical service, and that medical service might be taking care of heart problems. If you leave the hospital, you want to make sure you stay out of the hospital. If you come back to the hospital within 30 days, that's called a readmission. That means that your doctors may not have done a very good job in the first place because you just bounce back to the hospital. It's like buying something in the store and it breaks in a couple of days. So Medicare and some other payers actually assess you a penalty. So they would say that, well, if you actually bounce back to the hospital, you were going to have to pay a penalty back to Medicare so that you are now incentivized to make sure people stay out of the hospital. as a result, think about what this does. That may make the doctors in the hospital align with the nurses and align with the administrators in the hospital to really work together. They may even call the person who's outside the hospital, maybe your primary care doctor, and I'll put that as PMD, and say, well, look, we did all this care in the hospital. We need you to make sure that you communicate with the patient, make sure they're doing okay. They might even have home visiting to make sure that the patient is recovering okay and isn't getting sicker and getting readmitted to the hospital. So in this way, the team works together to prevent readmission. So that's a real kind of major change from before when there's fee for service, where if they got readmitted, you actually just got paid more. So this kind of concept of paying for performance is one step away from fee for service. People still get paid all their bills the same way they did before, so costs still increase because the volume and intensity and pricing still may be high. However, at least now there's some accountability for quality. Now that's a little bit of a change, and then there's sort of a bigger change, and that goes along with what might be called episodic care. I'm drawing that in a little bit of a yellow color here. And this is a little different. Suppose, let's getting back to heart surgery, you have a coronary artery bypass graft, or where they do this big heart surgery. Now, whenever you buy a big service like this, if you're a payer, you want to make sure that long-term quality is good. It's analogous to suppose you buy a brand new car. You might get a 5-year, 50,000-mile warranty with that. So you know that if something goes wrong, it's going to be covered. With episodic care, what that means is that if you have this procedure, you're going to pay one price. So you don't have those 6 or 7 bills from before. There's only one bill that's generated. And think about what that does. It makes everybody in that box we drew before, where you had the primary care doctor and the emergency room doctor, maybe the surgeon, the hospital, the rehab facility, they all need to figure out how to work together, because they all know that there's going to be one price and they all need to split that up evenly. So they're all going to say, well, what is the best value we can offer? We need to keep those costs low for this particular procedure. We're all going to be aligned and on the same page. And not only that, we also need to know that we're going to be measured on quality. So this is a big step over from just pay for performance, because not only are you measuring quality, but you're also creating incentives to sort of have the overall costs down. That's episodic care, and you can take that even one step further into what's called global care. In other words, here, it's not just a procedure like a coronary artery bypass graft or, say, another common procedure like a knee replacement, but you might say, we're going to take over this entire diagnosis. We're going to say, we're going to take care of all of your diabetes. We're going to take care of all of your heart problems. So in other words, not just that coronary artery bypass graft, not just that knee replacement you have, but everything related to this problem. So that's an even more expansive way of trying to offer services and sort of get everybody on the same page. And you can see that now it covers people not only in that system like we have in the episodic care where you have all those people in one box, but that box continues. It's all potentially for a whole year. So January through December, they all have to continue to work together, not just for that one procedure they did, but everything related to their diabetes or heart problem. And again, they're going to have quality metrics with that. And you can see that this is even a bigger deal than episodic care, because now people are thinking prevention. How are we going to keep people outside the hospital? How are we going to make sure they don't get sick in the first place? Because if we can do that, then we'll capture the extra savings, because that money that they paid to us, we keep that. So if we can keep them out of the hospital for long periods of time, that's more money for all of us, better care at lower cost. probably the most complete example now is to what is called full capitation or full accountable care. And this is sort of along the end of that spectrum. And very briefly, what this means is that an entire population of people, let's say you take all these people, all these potential patients, and you just go take all of them, and what happens is that you'll take all of the premiums, all the medical care, and just make one big pile of money. That pile of money then is given to an entire health system. So this is a large, either accountable care organization or other big health entity. And then that big health entity is going to assume all of the costs of care. Everything that happens to those patients has to be their responsibility. They measure quality. They make sure that overall they keep their costs in a budget, and they also have to be responsible for a variety of different quality measures. So that means it's not just paying for performance. It's not just an episode of care. It's not just a particular diagnosis of care. It's their entire lives of those patients have to be covered here. And that's felt to align everything better, to get better value for patients at better cost. We'll come back to these concepts in future videos to talk about them in more detail.